Thank you for joining us today for our Facebook Live session, How to Use Epinephrine Auto-Injectors for Treating Anaphylaxis. I'm Jennifer Gertz, the Executive Director of Food Allergy Canada, and our guest speaker today is Dr. Julia Upton. In today's session, Dr. Upton will review for us the different epinephrine auto-injectors in Canada for treating anaphylaxis and do a demonstration on how to use them. If you do have an epinephrine auto-injector training device, have it handy. You can follow along during the demos. If you don't have one, that's okay. The training device is not required for your participation in today's session. So before we get started, a couple of items. Just note that today's session is for informational purposes and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions that you may have regarding your own health or that of your child. If you have some questions during the session, please put them into the comment area and we'll get to as many questions as we can. And know that this session is being recorded and will be shared on Facebook and on foodallergycanada.ca afterwards. So you can watch it and you can share it with others. Now I'd like to introduce Dr. Julia Upton. Dr. Upton is a Canadian allergist who is on staff at the Hospital for Sick Children in the Immunology and Allergy department. She is an associate professor in the Department of Paediatrics at the University of Toronto. Dr. Upton is also the past section chair of the Anaphylaxis and Food Allergy section of the Canadian Society of Allergy and Clinical Immunology, and she's also a member of our Healthcare Advisory Board for Food Allergy Canada. So thank you, Dr. Upton, for joining us. I'd like to have you walk us through some of the basics of anaphylaxis, and I know we've got a few slides, so I'm going to pull those slides up and let's get started.
Great, thank you so much, and thank you for having me. Great, so we thought that we would just start with talking about anaphylaxis and allergic reactions, and just thinking about the signs and symptoms that can happen when somebody has an allergic reaction. So many of you are, of course, familiar with this, but signs of an allergic reaction in the skin are hives, which are itchy wheals, swelling. You can have swelling of the lips or face or tongue, and then there's also itching. You can be warm or have flushing redness. Respiratory reactions or breathing symptoms can be coughing or wheezing or shortness of breath. Some people get chest pain or a feeling of tightness. We sometimes have people have a hoarse voice or a change in the tone of their voice. Can have nasal congestion, sneezing, hay fever style symptoms where they get runny nose or itchy nose, watery eyes, sneezing, and sometimes a feeling of trouble swallowing. Some people experience an allergic reaction in their stomach or in their gastrointestinal symptoms where they have nausea or pain or cramps, and this can go on to vomiting or diarrhea. Cardiovascular symptoms or the heart symptoms or blood pressure type symptoms would be somebody looking very pale or having a weak pulse or looking very lightheaded or shocky, we call it, people feeling dizziness or actually even sometimes passing out. Then we also list symptoms about, we sort of think of them as other, but some people have a feeling, what we call an impending sense of doom. They feel very, very, very worried even before they necessarily understand or see all of these other symptoms. And we call that, this sense of doom or feeling something bad's going to happen. You can have headache. Women can have a feeling like they might get before their period, so uterine cramps. And some people describe a metallic taste in their mouth. So I think just going through those symptoms, and of course not everybody would have all of those symptoms or signs, but people can have any one of those.
All right, I'll advance to the next slide then, Dr. Upton.
Great, thank you so much. So we would then call it anaphylaxis, usually if it meets one of the following. So if you have a sudden onset of symptoms within minutes to hours after ingestion of a food, or a sting or drug or another exposure. And in the literature, we define anaphylaxis as having two or more body systems. So when we have those skin symptoms, respiratory symptoms, gastrointestinal symptoms, or cardiovascular symptoms, so two or more of those, or a drop in blood pressure alone. And the ones we worry about the most are difficult breathing or a drop in blood pressure or those throat symptoms. And you know, there's lots of different definitions of anaphylaxis across the world. One easy way to think of it is 2 or more systems involved or a severe system, such as the breathing or the blood pressure or that feeling in the throat. And that I personally just find that's one of the easiest ways to tell someone when to use Epi, 2 systems or 1 severe.
So now what about with hives? If you have just hives, is that the more common symptom, hives?
It's a great question. And, you know, that's why I like thinking about it as 2 systems or 1 severe, because, you know, a few hives you might treat differently than if you were absolutely covered in hives, especially if it came on very quickly and you knew that you had just accidentally eaten something or that you have an expected exposure. Right. The biggest difficulty, and we know from all of our allergic patients that the biggest difficulty is knowing exactly when to give epinephrine, because sometimes the symptoms don't progress. And although anaphylaxis is potentially life-threatening, it isn't always. And so we're really trying to give advice about something that could happen. And we want people to do the best that they can to try to avoid symptoms getting worse. And right. And so it's hard to know exactly when to advise for very mild symptoms. And that's somewhere where your doctor can weigh in about thinking about previous reactions, thinking about other risk factors that you might have. You know, for example, if you're peanut allergic and you know you ate peanuts and you're at the cottage, you may err on the side of using the epinephrine auto-injector for some hives, whereas, you know, there may be, you know, very mild symptoms in another situation you might not. And so those are the areas that are just harder to give blanket advice for.
Okay. But it is possible to have anaphylaxis without hives.
It is absolutely possible to have anaphylaxis without hives. And so when we think of those body systems involved, you can absolutely have anaphylaxis without hives. So you could have just a drop in blood pressure after a known exposure would be considered anaphylaxis.
Now, what about cofactors? I mean, we've heard some of the literature and we've seen some of the literature that cofactors can change the severity of a reaction. Can you speak to that piece as well?
Yes, so we know that people that have asthma that isn't well controlled are at a higher risk of having a more severe reaction. Sometimes we think that people that have had previous severe reactions are also at more risk. We know that there are certain things that stresses on the body that can make allergic reactions worse, such as alcohol, for example, or exercise. And so those would be considered some cofactors that can take what could be a mild reaction on another day and make it a severe reaction on a different day.
Okay, great. Okay, thank you for that. So let's move now to, so what does epinephrine do? I mean, you've got these ways to think about, is it anaphylaxis, but what does epinephrine actually do?
So when we think of the signs and symptoms that we went through, when we think of skin, for example, where you can have hives or swelling, the epinephrine actually counters that. So, you know, all of the systems that we listed, it basically counters those reactions. So in the skin, it constricts the blood vessels and reduces the hives, reduces the swelling. In the lungs, it actually opens the airways. And so when you're having an allergic reaction that's involving the lungs, the airways are becoming more narrow, and epinephrine opens those airways and allows the breathing to become easier. For the blood pressure, it actually constricts the blood vessels, and so it can improve the blood pressure and improve oxygenation. So basically it counterbalances whichever the reaction is happening from the allergic reaction to try to improve it. And that's why anyone that has used it, you know, sees quite a remarkable response, because it's kind of doing what needs to be done for these reactions.
Yeah, no, I've certainly heard that from my own son. Is like the effect is pretty pronounced and very relieving. So that's certainly good. Now, What about antihistamines? I mean, people have Benadryl in their medicine cabinets, and sometimes that's the go-to when you suspect an allergic reaction. What's your guidance on that?
Right. So how we use antihistamines and how we advise antihistamines is that they just don't act fast enough for the more severe or dangerous symptoms. So if somebody just started having an allergic reaction right now and took an antihistamine, we really don't expect the time of onset of the antihistamine to be helpful for the systems and the symptoms that we worry about: the breathing, the blood pressure, the throat. So taking it right then, it's not going to help. And then beyond that, it doesn't have the same, antihistamines don't have the same effect on the airways to open them the way we need. It doesn't have the same effect on the blood vessels to tighten them the way we need. Antihistamines are great for symptoms, in the sense that if you're very itchy, then they're helpful for that, but they're not helpful to prevent the worrisome symptoms that epinephrine can help with. And that's why we really advise that if you meet criteria for anaphylaxis, if you have multiple systems involved, or if you have severe systems, then you need to use epinephrine, or if you're not sure, then you use epinephrine. The antihistamines can also be used, but we would never want it to replace the epinephrine.
Okay. Now, we had another question from Zara on, what are some of the symptoms that you monitor for a drop in blood pressure?
Right. So somebody that has lower blood pressure might look very pale. They might be sweaty. They might feel lightheaded. They may feel faint. If not everyone knows, where pulses are or how to feel them, but many people do. And so, sometimes you can feel a weak or kind of thready pulse. And those would be signs and symptoms of low blood pressure.
Okay. Now, we also had a question from Rhonda around, does epinephrine give you severe anxiety, or does it do the opposite?
That's an excellent question. I mean, certainly we hope that sessions like this help to see epinephrine as a friend and a medication that's extremely useful. I often tell my patients that if you had 10 allergists and 20 emergency room doctors with you, and you have an allergic reaction, what would they do? They would give you epinephrine, and you have that in your pocket, in your backpack, and so so there's the psychological issue with, unfortunately, it is an injected medication, which we appreciate can have a mental barrier for some people. But if you're asking, does the drug itself create anxiety? For it can rev the heart rate a bit, and another word for epinephrine is adrenaline, and so it is one of these sort of excitable medications, but for many people it provides a sense of relief when they see how quickly their breathing improves and how quickly the hives start to clear. So
no, and it's interesting with my own son, it's kind of when he takes the epi, we remind him that you're going to feel your heart rate speed, so expect that. Interesting, a comment from Janice that she indicated 20 seconds and my symptoms disappear with epi. So certainly there's those that have used epi recognize its benefits, and I think it does take some of that fear away. Let's move on to what epinephrine auto-injector devices are available in the market today. All right, if you can walk us through this, Dr. Upton.
Yes, so there's now 3 approved devices, which is great. It's excellent to have choice because we're not all the same. So there's EpiPen, which comes in EpiPen and EpiPen Junior. So the Junior device has 0.15 milligrams of epinephrine, and the labeled indication for that is for 15 to 30 kilograms. And then there's the adult one, or the regular one, for 0.3 milligrams, and that's for 30 kilograms or more. And so older children and adults. Then there's ALLERJECT, and so ALLERJECT has a junior device, which is the same dosage as the EpiPen junior device of 0.15 milligrams. And again, that's for younger children, 15 to 30 kilograms. And then there's the 0.3 device for the older children and adults for 30 kilos or more. And then Emerade comes as 2 devices targeted for older children and adults. And so the 0.3 milligrams is for more than 30 kilograms. And then there's also a 0.5 milligram device, which is for 60 kilograms or more. And choosing which device you prescribe to somebody over 60 kilograms, either one can be used.
Okay, and so with the 0.5, because that obviously is new to the Canadian market, what would be a situation where you would prescribe the 0.5, Dr. Upton?
Yeah, so that's a great question. So, we, as a physician, we use intramuscular epinephrine or an epinephrine injection at a dose per weight. And so that's, you can see from that table as well that it's sort of decided by weight. And the largest dose that we typically use is 0.5 milligrams in the hospital or in the medical setting. And the way that we calculate what dose should someone have is it's 0.01 milligrams per kilogram up to 0.5 milligrams. So really anyone over sort of 60 kilograms, you might think about using the 0.5 milligrams. Having said that, for many years we've had 0.3 milligrams for that weight range, because this is being used outside of a medical setting. It's being used, people carry it and use it when they have a reaction. So I think there's no right or wrong way so long as the person's over the weight, but some of the things that a physician might consider for the 0.5 milligram dose might be prior allergic reactions, might be how far you are from medical care, the the weight, probably the larger that you get, more than 60 kilograms, you might consider using that 0.5 milligram device. So I think it would be quite specific for your history and your physician, which device you choose.
Okay, well, we have a question here from Aileen, who's considering switching from EpiPen to ALLERJECT. And the question she has is, what's the biggest thing I should know when considering switching?
Great, yeah, so we're going to go through the devices because they are quite different in their mechanism, whether you're taking off the front or whether you're taking off the back, and the form factor and the shapes. And so what's nice to have choice is that hopefully you can find the one that's right for you or right for your situation. And so in terms of if you're switching from EpiPen to ALLERJECT, you would want to make sure that you know how to use it, and you practice
I guess
with the demo.
Yeah. That's the same with all devices. You want
with
to
all
sure
of them.
You know how to, yeah,
absolutely, because they are quite different, and then also that you would want your people that are important to you or that may end up using it for you to also be familiar with it, because it is so different looking, the ALLERJECT, that somebody rifling through your purse might not immediately recognize it if they're not familiar with the device. So although it is clearly labeled, so things like that, you'd want to make sure that both you and anyone that might use it know that you have that device.
Okay, and now what about for Lindsay has asked this question, what's the advice for a child that's less than 15 kilograms?
This is an excellent question, and luckily the Canadian Society of Allergy and Clinical Immunology actually put out a statement about this a number of years ago. And the lowest dose in an auto-injector available in Canada is the 0.15. And if we try to teach someone how to use a lower dose, we would have to teach them, to use a needle and syringe and to draw it up, and really we know from studies as well as from observation that that's very difficult to learn, especially if you're not using it all the time, and the one time you would need it is an emergency. So the bottom line is that we recommend that the junior devices, the 0.15 milligrams, are used for people less than 15 kilos. Okay. And so that's not the labeled indication. That's what we call an off-label indication, or an off-label use, I should say. And it's really driven by necessity, because we don't have an auto-injector for that weight.
Right. Okay. So I want to go back on to another comment that's not related to kind of the dosing, but relates to signs and symptoms. And we just got a comment from Leanne around kind of the skin symptoms is that, you know, she had indicated that what she finds helpful is to guide people to look at a person's mouth and lips and inside as opposed to the skin, so that you know, because people can't often look at strangers and see, you know, pale or something on everyone's skin. So do care to comment on that, Dr. Upton?
Yes, so definitely. I mean, in terms of the color, so in some people you can see the paleness of lips, for example, more accurately than the paleness of skin. And often also the person telling you, you know, can tell you how they feel, but in very young children, I would presume we may be speaking about a very young child here to really be able to assess how are they doing. And yes, I mean, certainly as a physician, I look in the mouth.
Right.
We look for swelling. You know, it's just, it would really depend on the scenario and the situation. And right now, with everybody covered in a mask, it's an additional concern, right? Because you know, half of their face is covered. So I think it's an excellent point that we do need to be cautious, you know, for people that could be having allergic reactions. It is important to get all the information that you can. And so, yes, if you can see their mouth, that is helpful.
Right. Okay, great. So we've got another couple of slides that I think would be helpful for us to go through before we get to the demos. And one is just, okay, these are the devices, but let's go through where it should be injected.
Great. Yes, so the upper outer part of the thigh, I think, is very well shown in that picture. And so we really do want the upper outer part of the thigh, meaning that you can see this person's wearing shorts, but you can see where the seam of the shorts are, and you can see that that's just a bit in front of the seam. It's not around the back of the leg, it's not in the buttocks, it's the upper outer part of the thigh. And so, you know, when you see the person from the front, you can actually see the location on the front. It's not on the side, it's in the front. And, you know, I say the big meaty part of the thigh. And it's often actually, when you look, it's often where your arm naturally falls, it, you know, is a good location. So in front of the seam, you're aiming, you're trying to get it in that large muscle at the front.
Okay, great. Now let's talk a little bit about body position as well. So let's, in terms of what the body should be for giving epi.
Great. So because we know the signs and symptoms of an allergic reaction can involve having trouble with the blood pressure, we do like people to be lying down unless they cannot be. There are some people that if they are having a lot of breathing problems, they're much more comfortable sitting up. But in general, we do want people at the very least sitting or lying down. And then the epinephrine is in the upper outer part of the thigh. And then you can also support the legs, and that's that middle picture where supporting the legs even further helps take the work off the heart, you know, to be able to allow the heart, even if it's not working as well as we would like, it can still get the oxygenated blood to the brain. And then we also have a picture there of somebody lying on their side, because if they feel nauseated or they feel like they're going to vomit, it's best to be on your side so that, you know, you don't accidentally inhale that.
Okay, great. We got another question, but I just want to let Maddie know we're going to talk about the Emerade injectors in terms of how they function when we get to the demos. No, stay tuned here, Maddie. That question is due to be answered in a few minutes. So now let's talk about the 5 emergency steps. You've determined that you believe it's anaphylaxis. What are the 5 steps that one should take from here?
Great. Yes. So step 1 is to give the epinephrine at the first sign of a known or a suspected anaphylactic reaction. And then you would call 911 or EMS and say that someone is having an anaphylactic reaction. A second dose of epinephrine can be given 5 minutes after the first dose if there's no improvement or if the symptoms are coming back. And then we do advise to go to the hospital even if the symptoms are mild or have resolved. And, you know, step 5 we have there, you know, call your emergency contacts, you know, make sure that people know you're there or that you get the help that you need.
Now, Dr. Upton, can we just pause for a moment and talk a little bit about the safety of epinephrine? Because we certainly know, and research tells us that, epinephrine is underutilized in community in the treatment of reactions, and people are going to emergency departments not having used epi. And so, some of the themes around that are around concern around its safety. Can you just speak to that shortly before we go on to the demos?
Absolutely. So I think one of the things we have trouble communicating sometimes is that you're going this step 4, where you're going to the hospital or going to the emergency room, is really because of the allergic reaction. So the epinephrine auto-injectors are intended as emergency treatment of an allergic reaction. And all of the devices say that they want that allergic reaction to be treated by a medical professional. And that's why, it doesn't, using the epinephrine auto-injector doesn't replace seeking medical attention. And so that's, we definitely hear people say, well, I didn't want to use the epinephrine because I didn't want to go to the hospital. But if you're having an anaphylactic or suspected anaphylactic reaction, you really should be having medical attention, and you really should be using the epinephrine auto-injector. The safety of the devices is very good. I mean, there's no what we say in as doctors, there's no absolute contraindication to epinephrine. Basically, if you need to use it, then you use it. And it really does treat the signs and symptoms of the allergic reaction. And, when some concerns about it are certainly, injecting the thumb or accidentally injecting, we've definitely seen people accidentally inject their thumb, but when used correctly and used in the upper outer part of the thigh, then they are really very safe.
Right. And it's probably a good reason to have 2 devices as well, in case you do have the first injection is not properly administered. So
yes.
Another question that came in from Renee, and she references that within first aid, they teach you to rub the spot after you've administered epi. Is this something that has to happen? And if so, why?
So the idea of rubbing the spot is to increase the absorption of the medication from the muscle. And so it's a great idea if you can do it. If you have, we recognize that people are using this in an emergency. And so, it's sometimes it's not easy to remember every step, but yes, it definitely increases, it likely increases the absorption of the medication. And so if it can be done, then that's great to do. But I don't know that I don't think I'd beat myself up about it if in a panic I forgot,
Right. Okay. Well, listen, I'd like us to get on to the demo. People can see these devices. Now, everybody should know that these 5 emergency steps are available to download off of our website. So you can have that handy. But I'm going to stop sharing this, and I would like to turn it over to you, to Dr. Upton, to walk us through a demo of each of the devices.
Great, thank you so much. So this is the demo, or the trainer. They call it the training device of EpiPen. I also have the real one here, or what we call the live one, just to show you the difference, because many people have the trainer, and so as well as the real one. So it is nice to make sure you know the difference. This does have quite a few differences. The live one has a window so that you can actually see the medication, and it's a different color. The live one is yellow. So, but this is the trainer, and it is really good to practice so that you're used to the device. So on the EpiPen, you're taking the back off. And so the back is blue, so blue to the sky, orange to the thigh is what we often say. You're taking the back off. We want to take it off straight so that we don't, turn it sideways or break this pin. You just want to pull it straight off the back. And then it's the upper outer part of the thigh that we would just push the orange end into. And I'm wearing headphones, so you may not have heard the click, but it made a click. And then we count 5, 4, 3, 2, 1, and then you can take it out. So
now,
sorry, go ahead.
Sorry, Dr. Upton, one of the questions that came in about this, if you're administering this to a child who may not be able to sit still, what do you recommend in that situation?
Yes, so you do want to try to hold the thigh to
Okay.
be able to keep that still, because you do and the the label of EpiPen actually says hold for several seconds, and so you don't necessarily have to do the full 5 seconds. We often just advise people count down from 5 or even from 3, because time can be hard to kind of assess when you're stressed or in an emergency. But really, with a young child, the key pieces are to hold the leg and just try to get it in the right spot, and then
Okay. And so Zara here said maybe you'd recommend 2 people that might be needed to help administer, one to kind of hold the child and the other to kind of do the administering.
If 2 people are available, it would be helpful.
Great.
Yes. And
Okay.
I'll just note that you won't see the needle. So this has a needle guard. So the orange piece extends over the needle, and you won't see it.
Okay, so that's the EpiPen. So which is
Yes.
the next device you're going to share with us?
So the next one is the ALLERJECT. So this is the trainer, and this is the real one. This is the adult one,
Okay.
not the junior. So here's the trainer. So the trainer speaks. So I'm going to let it speak, and then I'll tell you more about it. So first you take it out of the case.
This trainer contains no needle or drug. If you are ready to use, pull off red safety guard. If to inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete. This trainer may be reused for training purposes. Replace the red safety guard and gray outer case.
So the ALLERJECT is quite different than the EpiPen. It's a very different form factor, and it speaks. So it is quite a different device.
But it has the same amount of medication in it.
Yes, it has exactly there's the ALLERJECT Junior and there's the ALLERJECT regular, and they have the same amount. They have equivalent amounts with EpiPen.
Okay.
Okay, and then this one is Emerade. I only have the demo for Emerade. I don't have a real one, but the real one looks quite similar, and we do have pictures in this presentation of how all the real ones look. The real one looks almost the same. It's just a little bit more colorful, and it doesn't say training on it.
Okay.
So for Emerade, you're removing the lid, the front, and then it's the same location. So the upper outer part of the thigh, and you just grip the device, push, and you can count down from 5 or several seconds. So 5, 4, 3, 2, 1, and done.
Okay, great. Okay,
So they're all the same, they're all given in the same place, but they have quite a different, they all have quite a different form factor that hopefully meets different people's desires.
Right. Now, we did get a question from Natasha on, and I guess this would be the EpiPen device, is, how hard do you need to press on the orange to get the orange piece down? And then maybe you can address that with all of them. Like, how hard do you need to press?
Yeah, so I think I will say when you did it, because so for all of them it is quite clear. You hear the click. So for the EpiPen, I don't know in terms of pressure per square inch how much, but it's very doable. And I'll show you just
Okay.
so you can see. When we advise how to use these, we often say to grip the device, with your hand and not put your thumb on the back, just in case you happen to have it the wrong way around. But I think, with the blue to the sky, orange to the thigh, people do tend to have them the correct way around. But, if you hold it firmly and then push, you'll get a feel for how hard you need to do it if you practice with the trainer. It's certainly very doable. But I would say, it's enough that it's unlikely you would do it accidentally.
Right.
And then the ALLERJECT
To inject.
is I would say similar amount of pressure.
2, 1.
And then whereas the Emerade, I would suggest, is a bit lighter, in
Okay.
the sense that it's not, it feels to me anyway that it's maybe just a little bit less pressure than the other two.
Okay. Okay. Now I know you were standing up when you were doing this. It was pretty
Yes.
hard on the video to be, but I guess you would remind them either to sit or to lay.
Good
Right.
point. Sorry.
Yeah.
Yes.
Yeah,
So-
no,
so
I know.
just-
We have some
yes.
limitations in this format to be
It's a very
able to
good
do
point. So just to show it, so you can see my leg, just to
Yeah.
show it, I did stand, but it's a very good point. I should be sitting or lying down. It's important to, and it's not a minor point because it is important to know where that location is in different views. So
Right.
maybe we'll just, again, when I'm sitting, so it's the, there's the seam of the pant,
Right.
it's the upper outer part of the leg. And so
And
again,
why
just-
is that so relevant, Dr. Upton?
So, we want we're going for an intramuscular injection. So we're
Right.
going for the big muscle at the front.
Got it.
And
Okay.
so I don't have a lot of muscles on the side of my leg.
Right. I
And then
got
we do-
it.
And then we don't want to go around the back just because there's too much important back there.
Right.
There's
Okay.
there's a major nerve that runs down the back of the leg. And so we just want to keep away from that. But
Okay.
in general, intramuscular injections are, the thigh is, and it's very accessible as well. And then some people may be familiar with using arms, but really the thigh is where we want because it's a much bigger muscle and
Mhm.
really in keeping with the question of massaging and wanting to get the medication into the body as quickly as possible. A large muscle does that much better. And so
Right.
that's why we like the upper outer part of the thigh.
Okay. We have a question here from Maddie on Emerade. Since it has a higher dose, would you still give a second dose?
So there are two versions of Emerade. There is the same dose as the sort of regular Allerject and EpiPen. Like so, the Emerade comes in a 0.3, similar to the other two, as well as a 0.5. So that's an excellent question. Does using a 0.5 instead of a 0.3 mean that you wouldn't need to give the second dose? How I would respond to that is we don't know if it would reduce the need for a second dose, but what we do know is that the second dose is given by the signs and symptoms that you see. So, even if you'd given the 0.5, if somebody wasn't getting better in those, after those 5 minutes, or if somebody's symptoms were returning, you would still give a second one. So it wouldn't, I hope that makes sense, that because you're giving the second one because the person looks like they need it, you would still be given. And so I would still suggest that somebody carries two devices. I wouldn't prescribe only one because it's the Emerade 0.5. Got
it. Okay. So now we got a question here from Kid and is asking for a comment on expired epinephrine auto-injectors. How long can you realistically keep those ones for, air quotes backup?
It's a great question. So there were some studies a number of years ago that showed that they actually, that the epinephrine auto-injectors last for longer than the expiry date, and that keeping it a few months after expiry is probably reasonable. I will say though that the companies have made some efforts to improve their supply chain and to improve their expiry dates when you buy the device. And so they don't necessarily have exactly the same amount of buffer on the end that they used to, because it was a common feedback from families that they don't want to buy a device that's going to expire in the next few months, right? So I think, a few months is fine. Hopefully there's less of a supply chain issue with the devices now, and that you can, keep a, within expiry or soon after device available to you.
Right. I guess, some of that's difficult to understand how people have stored their device, like if they've left it in the car during a hot day in the glove compartment, which they shouldn't be doing, I guess.
They shouldn't, yeah.
But I guess those factors into kind of the...
It's a very good point. Yeah, that, when they did do studies kind of looking at, well, how long does it last afterwards? They did tend to be in not extreme conditions either. Right. And so in an ideal world, a lot of the supply chain issues have been solved. And if they haven't, I'm sure Food Allergy Canada wants to hear about it.
Right.
But we do hope that having 3 different devices on the market has reduced the pressure on that.
Right. Yes, we hope. That's the plan. We had another question in from Lindsay around needle length. Okay. And so this person's curious about whether there's a concern about an injection needle going too deep for a baby or a young child, and that they understand that the allergic needle is actually shorter relative to EpiPen. Is that something that you have information on, or maybe we can get back to this individual at a different point in time if we don't have that information available?
Yeah, so in small children, it is a risk that it could potentially, hit the bone, so go all the way through and hit the bone. Having said that, there are ways to reduce the chances of that. And so, many of us are familiar when a doctor gives an injection, they actually pinch the skin. And so if you are using, a junior device on a thin child, or, somebody that's small, one of the ways to reduce that chance is to sort of, gather up the muscle and to give you the best depth that you can have. And, at the end of the day, it's the medication itself, the epinephrine, is still going to, if you need it for anaphylaxis, you wouldn't want to not use it for that reason, but you would want to be cognizant of that in a very slim person, that it is potentially a risk. And the opposite is also true, in somebody that does have more generous thighs, that would also be something to consider. That's one of the reasons that we like people to have multiple devices, so that they can get the dose that they need based on the symptoms that they're having.
Okay. Now, a question from Rhonda. Are there different epinephrine auto-injectors for being allergic to food versus something like latex?
No, it's a great question. It's the same medication. And, and I apologize if I also didn't make it clear. It's exactly the same medication in all of these devices. It's the device itself that differs, not the epinephrine. And epinephrine, intramuscular epinephrine is the treatment for allergic reactions, whether it's anaphylactic allergic reactions, whether it's drugs, sting, food, any of that.
Okay. Now, is there one device? I mean, we've got 3 devices, but is there a view that one device is better than the other? I mean, they all have epinephrine in it, but what's your perspective on that, Dr. Upton?
It's a great question. What I love is that hopefully you can find the one that speaks to you. And, it may be, I know some people that ask for multiple devices. They want one for the nanny, for example, that the nanny's more familiar with, or potentially the ALLERJECT because it talks, and then maybe they want one for a different situation that they're familiar with, or some people like the carryability. It really depends. And so the nice thing is they are quite different, and even the way that having Emerade with the front coming off versus versus EpiPen with the back coming off, all of these things may or may not be something that speaks to you, or the form factor of this one. So I don't think there's one that's better than another, but there may be one that's better for you.
Right. Okay, that's great. Now, let's talk a little bit about if you use an auto-injector to give epinephrine, but it wasn't anaphylaxis.
Right. So, it's definitely one of the largest tensions and difficulty in allergy is, the idea of, oh, well, did I really need to use it, and should I use it? But really, because, my simple way of saying it is, two systems or one severe, or if you're not sure. And so we would
Okay.
certainly rather that you give it than don't give it. Having said that, I do want to say again that, anaphylaxis is potentially life-threatening, but most of the time is not. And so, we're trying to mitigate risk. We're really trying to just give the best treatment that we know we can give. And because we are not very good at predicting severity and predicting what exactly will happen, we, in 2021, we tend to just advise, the very cautious approach. Do we hope to be able to, risk stratify people better in the future? We do, and we are very aware that the advice, many people are probably sitting there thinking, well, I had a reaction and I only did this or I only did that. The problem is that we just can't predict exactly what will happen. And that's why we want people to know what's the best treatment, what's the safest treatment, and, and then hopefully it's available to them if they need it.
Right. And hopefully research will help kind of tackle the question of severity, predictability. So yeah, that's certainly, we'd like to be able to make sure that continues. Let's talk a little bit about the time at which you, like, going back to the signs and symptoms, and sort of that, if it's past 4 hours, is it anaphylaxis, or, and kind of the speed of response to treatment. Can you kind of speak to those aspects of treating anaphylaxis, identifying and treating anaphylaxis?
So we expect severe allergic reactions to happen within minutes to hours. Certainly you can have a more delayed reaction, and you can have a reaction that gets treated and then comes back. And so the one that gets treated and then comes back is called a biphasic reaction, meaning that it has two phases. And so we know that some of the risk factors for a reaction coming back hours after the first one is that if the first reaction was very severe, or if there was a delay in the use of epinephrine. And so it can happen hours later. And that's another reason that in the severe reactions, or if two epinephrine treatments were needed, that there tends to be prolonged observation in the emergency room in those scenarios to have the medical team available if the reaction comes back.
Right.
And then, so if to have the first reaction happen hours after eating, for example, would be more rare. Having said that, there are some foods that we know can do that, such as some rare meat allergies and a few other things. So, I mean, I think in a person who experiences food allergy and a person that is at risk of anaphylaxis, it's important to recognize the symptoms and the signs, and really err on the side of caution for treatment.
Right. Okay. Another question came in about the Emerade, the 0.5 gram. Does that cost more?
Oh, that's a great question.
Now, I actually I can answer that.
Okay, great.
No, it doesn't. Okay, so that's the answer to that question. I didn't know whether you had a visibility into that, Dr. Upton, or not.
And well, is the question, does it cost more than the 0.3, or is the question, does it cost more than the other devices?
It's just, does it cost more? And it doesn't cost more. So
yeah.
that's.
I think Canada has tried to make the cost of the devices quite comparable. So the exact price I don't know, but I do know that there is an effort to not have a big discrepancy between one device and another, so that it really can be a personal preference rather than a cost issue.
Okay, a couple more questions that have come in. So it's related to allergic reactions. Do they worsen with exposure to an allergen? Because people have heard that. It's like the next reaction is going to be more severe. So what's the research say on that?
Yeah, so we definitely hear that a lot. It definitely is one of those things that every allergic person gets told, that it gets worse the next time. The factors that predict severity are so varied that it's very hard to predict what the next reaction will be. And so we alluded to it a little bit that, you know, for example, if I'm milk allergic and today I have a bit of milk, but I have a full stomach and it was only a tiny bit and I was just sitting around and I'm perfectly healthy today, then the reaction might be very different than if I accidentally drink you know, a latte that I thought was soy and it turns out to be milk, and I have a cold, and I just went for a run, you know, and a whole series of other things. So there's many factors that can influence severity beyond how many times have you been exposed.
Okay.
And
Okay.
we also know from, you know, emerging, you know, experience with oral immunotherapy or with allergen desensitization, that actually very routine exposure can change the threshold of reaction, or the amount that is needed to trigger a reaction, by reducing it. So I think that's a long way of saying that there's many more factors than how many times you've been exposed. And the second reaction isn't necessarily worse, but it's so hard to predict that that's why we want people to be prepared.
Okay. We got a question from Zedia, and I apologize if I'm not pronouncing all the names correctly, but this question is, do we give benadryl or reactant alongside an EpiPen in adult doses?
So, you know, how we usually answer this, we want the epinephrine to take center stage. You know, we don't want you to see them as equivalent. So we want the treatment of anaphylaxis and the treatment of severe allergic reactions to be intramuscular epinephrine. Also using an antihistamine is fine, but I really don't want to present them as equal or a choice, or
Right.
that if you don't have the antihistamine, you can't give the epi. I mean, the epi is the primary treatment, and antihistamines are, you know, they're symptomatic treatment really for comfort.
Okay. Okay. So first line treatment for anaphylaxis is exclusively epinephrine auto-injectors. And then if symptoms, you want treatment of symptoms, then you might consider it. Now, and is it different with benadryl versus reactant?
Well, so no, in the sense that we would keep that hierarchy, you know, that epinephrine is first and foremost, and the others are symptomatic relief. You know, once in a blue moon use of benadryl is probably fine, but you know, there's a Canadian Society of Allergy and Clinical Immunology statement about the use of that kind of antihistamine versus the newer ones, and the newer ones are quite different. They treat the body, but they don't penetrate into the brain very much, and so they don't cause the same levels of sleepiness, driving problems, learning problems, and some of the other, we call them anticholinergic effects, like having dry mouth and things like this. So the side effect profile of the newer antihistamines is much better than the what we call first generation antihistamines. So in general, we advise the newer second generation antihistamines over the first generation.
Okay, and second generation, give us some brand names on that so we know what that means.
So reactant, Arius, Allegra, Claritin,
Okay.
Rupall, Blexten.
Okay, terrific. Okay, great. Okay, listen, I think we've only got a few minutes left, so I want to thank you, Dr. Upton. This has been great to have you available to answer our questions, and we really appreciate the engagement of the audience and the questions that we're We have covered off a lot of information today, so I want people to know that they can find additional resources on our website at foodallergycanada.ca. Like we have a Anaphylaxis 101 video. We have a youth video where youth are sharing their reaction stories, their allergic reaction stories, which is, you know, and the lessons that they learned from that. So if you have a teenager in the house, that might be worth checking out. Certainly the 5 emergency steps that you covered off earlier, Dr. Upton, are also available on our website. We've got a Think Fast poster that really helps build kind of community awareness on the treatment of anaphylaxis. And we also have another webinar that we did in June with Dr. Moshe Ben-Shoshan on understanding the use of epinephrine. So if people want to dig a little bit deeper into the subject, that's available there. We also have, and it's a collaboration with the CSACI, the Canadian Society, is an allergyaware.ca, which is a 30-minute free online course. And it goes through the basics of anaphylaxis and how to reduce risks, as well as the recommended emergency treatment. So a lot of the same information that we covered today. But you know what, I found those ones helpful, especially with grandparents. I had them take the course because it's just, again, it's not as much about, you know, you want your friends and relatives and caregivers to have access to that information as well. So as we close out the session, I'd like to just go back to you one more time, Dr. Upton. Give us some key takeaways from today's session. What would you leave with our audience?
Great, thank you so much. So I would say if you're unsure about a reaction, really the safe choice is to use the epinephrine auto-injector. We know that the earlier you give the epinephrine, the better the outcomes are. And practice with a training device. I hope you practice and know how to use it, and that it becomes, you know, sort of a friendly device rather than something to have fear from. You can get, if you don't have a training device, you can get it from, if you have EpiPen, you can get it from EpiPen.ca, or you can get it from ALLERJECT.ca, or you can get it from Emerade.ca. And so it is really worth having a training device. And then, you know, as Jennifer mentioned, there's lots of resources on Food Allergy Canada to try to help you through this journey.
Great. Okay. Thank you so much, Dr. Upton. Just a couple of closing comments from my end. As many of you in the audience are aware, and I say this with every event that we do, Food Allergy Canada is a not-for-profit organization and a charity, and we are reliant on the donations for the support for the work that we do. So if you can consider a donation to our organization, we would certainly welcome it. And you can do that by going to foodallergycanada.ca/donate. We'd also like to thank the sponsors for the event today. We have the Walter and Maria Schroeder Foundation, the Sean Delaney Memorial Golf Classic, EpiPen, and the Peanut Bureau of Canada. And I'd also like to mention that we've got some other webinars that are upcoming. On April the 29th, we have Understanding Oral Allergy Syndrome with Dr. Ann Ellis. The registration for that event is open, so we encourage you to sign up on our events page on our website. And that concludes our Facebook Live event. So thank you everyone for your participation. We really appreciate your time, Dr. Upton, and everybody engaging in this important subject. Thank you.
Thank you.